We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, Jess, what is cooking?
Hi, Nikki. Well, it's holiday season, so let the baking begin.
Absolutely. You know, I absolutely love things with apples in them. I love apple pies and fruit cobblers and all the fruit stuff around the holidays. I think is so good. Which
Me too.
You know, why doesn't all the fruit in the basket get moldy at the same time?
I don't know. That's a good question.
It's because mold is sporadic.
Oh, Nikki, we can always count on a fungi joke from you.
I'm a fun guy. Oh, okay. All right. Well, speaking of spores, today we have with us Dr. Geetika Sood to discuss Clostridioides Difficile, or C. diff spore survival in healthcare environments. In her research article, Does Clostridioides difficile infection in a previous room occupant predict CDI in subsequent room occupants across different hospital settings? So Dr. Sood, MD and Masters of Science, is an assistant professor of medicine and hospital epidemiologist at JHBMC, completed medical training, a residency in internal medicine, and a fellowship in infectious diseases at Temple University Medical School. Dr. Sood previously worked at Albert Einstein Medical Center, a 500-bed community hospital affiliated with Thomas Jefferson University, where she started an antibiotic stewardship program. She was actively involved in medical education as an associate program director for the internal medicine residency program and a clerkship director for Jefferson medical students. She also served as hospital epidemiologist at Abington Memorial Hospital, a 600-bed community hospital outside of Philadelphia. She's been the hospital epidemiologist at Johns Hopkins Bayview Medical Center, where she led several successful process improvement initiatives, resulting in her winning the Armstrong Clinical Excellence Award in Patient Safety in 2015. Very impressive. She's active in the Society for Healthcare Epidemiology, and her research interests are in the role of the microbiome in healthcare infections and using big data to predict healthcare-associated infections. So thank you for sharing your research with us today, Dr. Sood.
Thank you so much for having me. Very excited to be speaking with you about the study and about C. difficile.
Great. Yes, welcome. So can you start us off today just by telling us what prompted you to dig deeper into this area?
Of course. So as many of you know, and as many of you work in hospital epidemiology and know how much we worry about C. difficile, both for our patient safety and for preventing infections in other patients, we know that there are so many factors that are involved in the development of infection. We know that there are clinical variables, we know that there are environmental variables, and we know that there are certain levers that we can pull to potentially help reduce the risk of transmission. We know that the environment is incredibly important in the transmission of C. difficile. So we wanted to look a little bit more carefully at how much the environment impacts the risk of C. difficile in our patients.
That's fantastic. So the article starts with the statistic that an estimated 236,000 cases of hospital-acquired C. diff infection occur in the U.S. annually. So that's a lot of patients that are, infected with C. diff. I'm curious if this is a recent statistic. So I ask that because from my personal experience at our facility, we have seen that there are some patients who may be what we would consider inappropriately tested because they don't have symptoms necessarily of C. diff, or they get tested later past the time that those symptoms were detected and are considered hospital acquired.
Mm-hmm. Yep. We've had the same issue, Jess.
And us too. Thank you for bringing that up, Jesse. I think that's such a great point. The diagnosis of C. difficile can be complicated for lots of reasons. The test itself is often oversensitive, so that if somebody had C. difficile before, the test can still be positive now, or somebody may be carrying the C. difficile organism and not actually have active disease. So you're absolutely right that diagnostic stewardship and being able to identify the right people to be tested is a very important component of helping to identify who actually has C. difficile infection. I think you also alluded to another point, which I think is very important, is that the incidence is evolving and changing of C. difficile. And over the past few years, thanks to all of the work that all of you have been doing and you and Nikki have been doing in your hospitals, the incidence of C. difficile has been going down over the last few years. So hopefully we'll continue that trend as well.
Yeah, hopefully. It's been a journey to lasso that in for sure. And before we move on, I just wanted to clarify a couple of terms that I haven't heard before, and I think maybe the listeners might need some clarification on, and that this could just be me. But what is incident CDI and colonization pressure, and how do those relate to transmission?
Also, very interesting questions. Thank you for bringing that up. And you're right that sometimes we use these terms that may not be so clearly defined. So incident CDI, especially the way that we used it in our paper, was specifically looking at patients who had a new diagnosis of C. difficile. We wanted to separate out those patients that had recurrent C. difficile or patients who were persistently positive because inappropriately testing, as you pointed out, Jesse, people were testing more frequently than they needed to after the initial diagnosis. This idea of colonization pressure, I think, is a very interesting idea. It's sort of the converse of herd immunity. So just like with herd immunity, if you have a lot of people that are already immunized or already have the disease, you're less likely to have transmission just because the burden of disease in that environment is less. Conversely, colonization pressure, which is a relatively newer idea, is that more than just each individual person contributing spores or contributing organisms to the environment, the collective number of people who are potentially infected may contribute an exponential amount of spores or infectious material in that specific environment. Okay. So it's an evolving area and new and exciting.
Yeah, that's neat.
That's really interesting perspective. So you mentioned earlier on, as you were talking about the digging deeper into this topic, about the variables. There's so many variables that could contribute to a patient acquiring C. diff. Can you talk a little bit about what individual patient risk factors might be associated with acquiring C. diff, and whether these could increase or decrease that risk?
Great point. And I think one of the areas that we're continuing to learn more about, but as you're bringing up, the development of C. difficile disease is actually a multi-step process. So the first part is acquiring the spores or acquisition of the disease of the organism, and then the development of disease. And the second part may not happen. The first part are areas that hopefully we can help control and mitigate, although we see C. difficile spores out in the environment and outside of the hospitals as well as in the hospitals. As far as the development of disease, I think one of the things that you and I struggle a lot with is certainly the administration of antibiotics, because we know that once we disrupt the normal microbiome in the colon, that allows organisms to grow that really shouldn't be there and to actually cause disease. Antibiotics, of course, being one of the most important variables. Also, any other host factors that make your microbiome a little bit less normal would increase your risk of C. difficile. So if you're immunocompromised, if you have other conditions that alter this microbiome, that makes it more likely that you will acquire this disease, not just the spores.
So I imagine that, if you have this intensive colonization pressure and then you also have additional risk factors, that those types of patients, you would have a much higher expectation that they would develop a C. diff infection.
Absolutely. And of course, the third part being that if they have risk factors, they may actually end up having more severe outcomes related to the disease, as well as, unfortunately, developing the disease.
Yeah.
Yeah, and we all know how important antimicrobial stewardship and using the correct antibiotics, et cetera, recognizing risk factors and all that jazz. But I want to talk about cleaning, and I'm curious about the two different types of room cleaning that your involved hospitals employ. So one is bleach for CDI rooms or C. diff infection rooms. And the others used the oxide and oxycide and UV where possible. Do you have any data that supports one type of cleaning over the other? And do you know how often or when the affected rooms in the hospital that used UV where possible were cleaned with UV? It just seems like a lot of variables in the study, and some of them are unknown variables.
You're absolutely right, Nikki. And that's an important point, both for the study in that that's a confounding variable, because we didn't actually look to see which cleaning method was more efficacious in preventing C. difficile transmission from a previous room occupant compared to another. And you bring up a really good point that certain types of cleaning responses are different and potentially better than others. So while our study didn't specifically address this, we do know from the literature that there are certain elements that we should be thinking about. For example, we know that patients who are colonized with C. difficile, even if they don't have active disease, shed this spore in their environment. Thus, if you can clean those rooms better, you're actually going to reduce transmission, even though you may not know that that person has C. difficile at all. So that sort of goes along with the idea of using sporicidal agents, because we know that this organism is difficult to clean in even those rooms that we don't know the patient has C. difficile.
Mm-hmm. Okay.
I don't think we fully know what the best answer is for cleaning. We do know that different hospitals, including the different hospitals in our health system, this study was looking at all of the hospitals in our health system, use different approaches. Many hospitals are using regular disinfectant for general room cleaning and then sporicidal or UV cleaning in those patients that have had known C. difficile.
Yeah.
Some hospitals are using oxycide, a sporicidal agent, throughout, and some of our hospitals were doing that. So thank you for that important question.
It's just an interesting extra arm of the whole C. diff saga. There's so many variables that go into figuring out how we eradicate this, and it's hard to wrap your arms around all of it in one fell swoop.
Exactly. And I think all of our listeners probably struggle with this as well.
Yes. Yeah, I'm sure they do. Yeah.
Yeah, and I think one of the things that we struggle with is when we look at things like this, because there's so many variables, what variable causes an increase, what variable causes a decrease, and do we have to treat this sort of like a bundle where we do all the elements 100% of the time in order to be effective in decreasing our HAI rates? So leading up to that why isn't the environmental cleaning enough? Is it these other variables, or is it that the rooms just aren't being adequately cleaned? What do we think is the biggest impact here?
So a great point, Jessie. I love your bundle idea, and I think we may have to adopt more of that in our hospitals. I think that's so important. And also really important and great idea about what are we missing? Given that we have control over many of these variables, we should be able to reduce our rates even lower. And I can tell you at my hospital in particular, that's been a challenge even with the enhanced cleaning methods and a lot of other implementation exercises for C. difficile as well. I think you're right that that it is multifactorial. For example, patients may come in with C. difficile already in their body, and then the things that we do to try to help the patient may actually end up hurting them related to C. difficile. For example, there are patients who do need antibiotics, so that may not be entirely preventable. Also, your point about cleaning, I think, is a very important one. It's something that we've also addressed in SHE conferences, in that it's not just the effectiveness of the disinfectant, but also the human factors approach of how effectively you're cleaning. And you need both. So an agent can be 100% sporicidal and effective in killing spores, but if you're not implementing cleaning in all the surfaces that need this extra enhanced cleaning, you're going to still have levels of transmission. And that was part of the reason for the study too, is to sort of understand that how much of the environment is playing a role in C. difficile when we think that we're actually doing a pretty good job with cleaning.
So where do you think, or where do we as the medical community, where do we think the biggest reservoirs are in the patient rooms?
Thank you for that question. I think it's you and I are probably thinking in many of the same ways. Certainly, all of those areas that are high touch are likely to be reservoirs for C. difficile. I think there may be other areas that we think about less frequently that may be hidden reservoirs that we don't think about as much. For example, bedding. There's so many complex moving parts in the patient beds that can be reservoirs for C. difficile. Places that we may not be thinking of as high touch may actually be holding on to this spore for such a long time, since we know that it lives in the environment for a very long time.
Mm-hmm. Yeah, linen. I forgot about that.
Linen. Good point.
Ugh, linen. So one of our big topics for discussion at healthcare facilities across the world is hand hygiene. How does hand hygiene play into all of this?
Also a really interesting question. I think we know that washing with soap and water is more effective than alcohol. However, having said that, I think it is important to note that even when you wash with soap and water, you still have a lot of residual spores on your hands, as has been studied previously, and that alcohol, while imperfect, is still better than no hand hygiene. And in areas where you don't have high rates of C. difficile, alcohol use generally hasn't been associated with higher rates of C. difficile in those environments. So absolutely, soap and water, it would be better in those patients who have C. difficile. Alcohol is also an effective agent. So being able to use some sort of hand hygiene, even when you don't know that a patient has C. difficile, would be very effective. Mm-hmm. And it seems like it's a simple intervention, but so challenging to get hand hygiene compliance up to the levels that we want it to be.
Just clean your hands, people.
I know. It sure is difficult to do. I don't know why. Oh, boy. So, Dr. Sood, what recommendations do you have for healthcare workers to help mitigate the transmission of C. diff in our facilities?
So thank you. That's an area that I think we're all working on so diligently. I think all of the points that you raised are important to address in the bundle approach, as Jesse suggested. Certainly making sure that people are doing hand hygiene, soap and water for those patients that have C. difficile, and alcohol if not, because you don't always know who's actually colonized with C. difficile. Improving cleaning, both in terms of the human factors in process and also potentially considering sporicidal agents more broadly, as many hospitals have been doing to help reduce environmental contamination from those patients that are colonized. And as we discussed, antibiotic stewardship, reducing unnecessary antibiotics as much as possible, should also be a big part of the plan and strategy. Yep.
Yeah, everything we do seems to be a bundle. There's so much evidence-based practice out there for all these healthcare-acquired, not just infections, but conditions. And, you just have to bundle all of these activities together to really see effect.
So this brings to mind to me, so we asked about what healthcare workers can do to help mitigate transmission, but what are your thoughts on education for patients and families while patients are admitted to our facilities?
Thank you. That's a struggle that we often have because families don't necessarily understand transmission and infection prevention practices as well as healthcare workers hopefully do with all of our training. And so I think emphasizing gowns and gloves when they come to visit their family members is certainly incredibly helpful. Having them understand the importance of hand hygiene and soap and water and reducing transmission risks, and potentially helping ask them to partner with their loved ones to ask their clinicians and providers, do I need this antibiotic? Are there other things that we can do that may not require these microbiome disrupting therapies?
That's great. Yeah, that sounds like great tips for our patients and our visitors as well.
Yeah. Yes. My goodness, there's so much to talk about when it comes to C. diff, and we are so thankful for you joining us today. So we really appreciate it. Do you have any additional takeaways for the listeners today?
Not more than we've discussed, except to thank you all. I know all of you are on the front lines helping to prevent not just C. difficile, but all kinds of healthcare-associated infections and conditions, as you pointed out, Nikki. So thank you, everybody, for all of your work in COVID and post-COVID and for helping keep our healthcare workers and our patients safe.
Mm-hmm. And thank you. It's definitely a team approach.
Yes, thanks so much.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AJIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AJIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at ajicscienceintopractice.org. That's AJIC scienceintopractice.org.